As a dermatologist, I am obviously very interested in the cutaneous toxicities of immune checkpoint inhibitors, but there's really not a lot of data out there looking at population-level evidence of the impact of these toxicities on overall survival in patients treated with immunotherapies. So what we did in this particular study is we looked at a broad population of United States and European cohorts, approximately 92 institutions, representing over 200 million patients enrolled in the registry, to see for the patients who develop cutaneous immune-related adverse events in the setting of immunotherapy, how do their outcomes compare to those who don't develop these toxicities? We had roughly 7,000 patients in each the study arm and the control arm, so 14,000 patients matched on a number of covariates, including demographics, cancer type, and immunotherapy type. And what we found is that patients who develop these cutaneous immune-related adverse events, they tend to have better prognosis than the ones who don't, on the order of 0.4 to 0.7 protection from mortality, and this is overall survival. There were differences between the types of morphologies for these cutaneous toxicities. Obviously, there are specific morphologies such as psoriasis, vitiligo, lichen planus, atopic dermatitis, and then non-specific morphologies like pruritus or itch, morbilliform drug eruptions, rash, or other non-specific eruptions. We saw that the specific morphologies tended to have stronger protective effects, ranging in effect from 0.4 to 0.6 in hazard ratios, and the non-specific ones tended to have less significant or less clinically significant effects, so ranging in effect from 0.6 to 0.8 in hazard ratio. Overall, there was about a 22% protective effect from development of any toxicity by comparison to patients who did not develop toxicities. And we did robust adjustments for what we call guarantee time bias, because toxicities are competing with death in terms of their development. So a patient has to be alive long enough to develop a toxicity. And even after adjustment for these statistical methodologies, we still found that the effects was significant and protective. Up till now, there was really a lack of evidence of understanding how these toxicities, and specifically cutaneous toxicities, which are the most common, really impact patient outcomes. And often patients are obviously very symptomatic and they have to be treated for these, but we didn't know if there was any benefit from having them. Now we can counsel our patients and provide them with information that actually developing these toxicities can be helpful to their treatment response. And maybe that would influence our understanding of how immunotherapies respond in some patients and not in others by studying the mechanisms of these toxicities specifically.